I think, as Chip also mentioned, everything today in pediatric practice and primary care practice is increasingly involved, not just the care that we do, but looking at the data and measuring the data. It's really important for us to be looking at the financial data, the business data of our practice, but I think we are also appreciating that we are living in a world now where people are looking at practice performance, not just based on your business metrics, but on how you are doing in quality. And quality is an area that is being measured for all of our practices, or almost all of our practices. And we are moving into an era more and more of value-based care. Almost the big chunk of our practice revenue still comes from our traditional business model. But increasingly, more and more, practices are able to receive additional payments based on quality performance. And this is more, it's not just good for care. It's not just good for improving community metrics. It's good for business. So we actually have a tag team now that involves two of our fabulous medical directors from our Pediatric Health Network, Claire Boogaard and Ed Fox. Both of them arrive at this stage as primary care pediatricians through slightly different routes, but been there, done that, understand what you all are going through, and I think that helps. So we're going to chat a little bit about value-based care. We're actually doing this in two chunks. The first part of the presentation is just going to be setting the stage on where it's been and where it's going. Then we'll have a break, because we all need a break. And then on the other side, we will be getting into some nuts and bolts about, here are those actual measures. Here's what's in the numerator and denominator. And here's what practices are doing to actually improve their performance, because improving quality performance also is improving revenue to your practice on value-based care contracts. Got it? All right. So we have a lot of learning objectives, and you can look at that on the slides. So the big idea is applying and you'll let me know when I'm done? Okay. All right. We're applying what is the value lens, and how do we use it to transform care for our patients? And actually improving care at the patient and practice level improves outcomes for populations and community metrics as well. And it also helps with our healthcare workforce. So, am I doing this part? Okay, here's the journey. And here is Claire Boogaard.
Thank you. Hi, everybody. Thank you. So I think appropriately, I'm going to start with what is value-based care, because having studied medicine, public health, taken many classes on this, read articles in the newspaper, I still had many questions when I started this job. So if you are on my journey, the next couple of slides will help you. So this is how most of us enter this stage, where there's a lot of acronyms being thrown around, a lot of assumptions that we all are speaking the same language, but really in the end, a lot of experience comes with understanding how these mesh together. Very similar, going off of what Dr. Weissman said, is that historically, we have been in the traditional healthcare system in America, which is focused on fee-for-service, or giving you payments for the work you do based off what you say you do. But as we know, as pediatricians or as healthcare providers, that doesn't always match with the mission, which is trying to get people healthier and keep them healthy, and therefore out of the clinic, so we don't see them and don't have to charge for them. So value-based care is something that you might hear a couple different ways, whether it's based on value or the quality of the care you deliver, the satisfaction that your patients have with your practice. But really, value is pretty simple. It's the quality of care you deliver over the cost. So higher quality, lower cost equals higher value. Now, for generations, they've been trying to push this in this direction of value-based care. And the Institute for Healthcare Improvement, the IHI, which is one of those acronyms, decades ago came up with the triple aim for this kind of work. And that was to improve population health and clinical outcomes, to reduce cost, and improve the patient experience. And if we did that, then the value would come along. Over the last couple decades, they've actually expanded that to the quadruple aim, which means improving provider experience, because we know then that contributes to the value and care we deliver. And of course, and not to be forgotten, advancing health equity. So many of us are familiar with what's on the board on the left-hand side, which is the fee-for-service model. This is focused on individuals. This is trying to get compensation for what you're doing and the incredible amount of work you're doing. But it's not dependent on outcomes. It kind of keeps us in silos. And we want to go from that quantity based reimbursement model to the quality reimbursement model, which is this value-based care. So this is an example of an alternative payment model, but that's something that focuses on quality and actually gives you money for it. And payments per member and shared savings are more important than the charge for each individual service. This also helps us look at our data on a population level and really incentivizes collaboration.
So next stop on our journey is to talk a little bit about, so how is this baked into our health system, into our practices, what we are doing? And so this is a pretty busy slide, but I know that when I've had these conversations, and I think why it matters is I'll refer back to that great quote unquote provider meeting we all have with all of our providers, and our office teams come in and they try to like motivate us to and impart to us as to why it's important to pay attention to this. And, you know, why do I really have to go into that little box to click for the 10th time something else? And, you know, I don't have time to do that. So what's going to motivate folks to do this? And so I think where we're heading is to the idea that there's this reimbursement model, but then how do we do that? How do we deliver that care? And I know for me, part of the alphabet soup is this whole like CIN, ACO, PCMH. How are these things different? They're all slightly different nuanced models for moving in the direction of that quality space, right? And so, and how I like to think about it a little bit, because if we look under all of those three sections on this slide, the Venn diagram, what we're looking at is models to basically improve quality, improve value, right? And hopefully decrease costs. And so those factors are under all three. But if I can highlight, a lot of us, you know, our practices belong to a clinically integrated network, the PHN. A lot of us are here today, right? And maybe that's all we do, right? We're just part of a CIN. We don't necessarily have an ACO contract. PHN happens to have one, but maybe you're just part of a CIN, but you don't have an ACO contract, and maybe you don't really do the whole PCMH approach. And maybe you're a practice that's not part of a CIN, but you do your PCMH certification, and you know, you sort of believe in that philosophy, that approach, and so you're in the Venn diagram. You're in the circle with just PCMH, and then perhaps you just happen to have a contract with a program, and you're part of an ACO, but you're not really part of a clinically integrated network, and you don't necessarily do PCMH. So then you're in the ACO circle. Once you're in one of these circles, the likelihood of you being in more than one circle goes up, right? And so for those of us who belong to practices that are part of the PHN, for example, you're right smack in the middle, right? You're part of CIN, the PHN, which happens to have an ACO contract that the grand majority of PHN practices have signed on to. And a lot of us are also doing PCMH work and making sure we're doing our certification, right? So you can be in all three of these and you're right smack in the middle, or you can, you know, sort of getting your feet wet with one or just two of these circles. And so how I think of it is CIN as an organization structure. It allows practices to come together to sort of collaborate and actually be able legally to negotiate with payers. And then PCMH is an approach or mission or philosophy, and an ACO is a specific value-based contract, usually targeting a specific group of patients. And not to make us feel alone, but rather we are part of a large group of pediatric accountable care networks across the nation. You'll see many names under the 3 boxes. And on the left, you have folks who are involved, like the PHN is, on pay for performance and shared savings. Basically, we have contracts, developing contracts where we're on the upside of sharing, right? So we come to an agreement. We all agree that if we hit certain quality metrics, that we're going to be eligible for a shared savings component, right? So if we, as part of our work, actually end up saving the payer money, the payer has agreed in our contract to go ahead and share some of those savings with us, as long as we hit certain quality metrics, right? We get scored on this. As you move along the continuum here to the right, you start to also enter territory where not only are practices going to share in the savings, but potentially we're going to share on the risk side, right? And so and you can see that as you move to the right, you end up at sort of the end where some institutions are actually running the insurance program itself. And behind, while we look at some of this, sometimes I look at these names and I'm like, well, those are big academic institutions. What does that have to do with me? Right. The reality is that most of those institutions, just like locally, they have community practices that belong to their CINs who are behind the work that they're doing. And so no longer do these names just represent academic institutions, but rather more regional networks of practices just like ours.
All right, great. This little dance and switch made a lot more sense when we were on Zoom. So I'm sorry for move around so much. So the big question is, do these value-based care payment models work? And I'm going to pause for a second before I go into this slide. It's a little busy, but I think it's easy to think about in the adult context. If you have a very sick adult who's using a lot of emergency care or a lot of end-of-life care, and you're able to work with that patient and minimize utilization, that makes sense. The return on investment can be seen pretty quickly. In pediatrics, we all know that's different. In fact, in pediatrics, the more we see them, the more we can prevent those long-term costs. And so proving that to the payer is really difficult. But what's cool is that within all these models, we are still able to show that these kind of payment structures and models do have a positive impact on cost. So Partners for Kids in Ohio released some data that shows that essentially their accountable care organization was able to minimize their per member monthly costs compared to fee-for-service or managed care models. And that's that red line on the left-hand slide. Although it did still grow at $2.40 a year, it was still the rate of growth was much less than other models. And then if you look at utilization, the more we work on quality and the more we work together to help these patients through care management structures, we actually really decrease the utilization, which is something that we can work to show payers is advantageous for their pockets pretty immediately. Dr. Fox said, there's multiple different models for value-based care, and PCMH being one of them. And this just highlights, as many of you guys already know, that these quality improvement models do improve staff satisfaction, and they have a lot of benefits on the patients, whether it's because we're getting better anticipatory guidance or they were able to see a consistent caregiver, or really how they use medical care. So decreased outpatient sick visits or antibiotic use.
And then how do we measure value and how do we capture the data? So getting back to Chip's point, so data is the information, it's the science, it's the map of figuring out how to move from that whole sort of volume to value. Without the data, we have no idea where we're standing today, and we have no idea how we're going to get to where we want to go. And I think that that's the piece where when we are at those meetings with our practices, when we're talking to each other and be like, no, it really is important how we do this and how we collect it and how we document it in our EMRs, because if we're not doing it correctly, we're never going to get good information. Our map is really not going to be very useful. And that's hopefully what will motivate us to sort of, I do think that we can do a lot of work, and that's the second half of this talk, to make it easier on all of us, because certainly, a lot of us are experiencing a lot of sort of burnout and fatigue. And the last thing we want is someone else to come in, hey, guess what? We now have a new contract with so-and-so, and they want us to measure these 10 new measures. And we're like, like how are we gonna do that, right? And so, so who are the people who get to make up these measures? And, what measures, who gets to define what data is important for us to track? And so one of those organizations, and pretty important one, and so we will highlight it today, is NCQA, right? The National Committee for Quality Assurance. And they've been accrediting payers and making sure that payers, follow good citizen policies, if you'd like. And then they've also been providing some accreditation and certification for practices since about the early 2000s. The main one that we are mostly familiar with is the whole PCMH certification. And one of the other really important things they do is that they maintain this thing called HEDIS, right? And so for those of us who are used to hearing about some of these measures, and some of those benchmarks that Chip was mentioning are, also have sort of corollaries in the whole HEDIS measure set. So NCQA basically manages that information set. And those measures are, things from well visit to vaccines to, compliance with using antibiotics appropriately. There's a bunch of different ones. There's like 90 measures, at least, probably more now, that's 2023, across 6 domains of care. And the other really important thing we're going to highlight today is at the bottom, just because this is going to dictate some of our ongoing work, is that there's movements already to start to stratify some of these measures by race and ethnicity, and eventually language. And so as we start to provide some of that information, one of the reasons is that HEDIS will start mandating that we are looking at that information. So it's a good thing to do, but now we are going to be required to do it, right? And then the other really important thing that we are all hearing a lot about and trying to figure out how to do it and how to code for it and how to translate our work into something that counts around social determinants of health, right? A whole other topic and sort of discussion would be around the importance of SDOH screening and providing resources. But here we're going to talk a little bit more like in the sense of we will have a measure on SDOH. Who gets to define that measure? Who gets to dictate what tool we use, what tools count, and what, almost just as importantly, what codes count when we're relaying that information? And do our patients really want all these codes all over their charts, right? And then who has access to that, right? So these are all things that, it's a constant evolution. It's quite messy. One of the nice things about going to some of the meetings with some of those other groups on that side with all the other groups from across the nation is that you realize everybody else is in the same mess, right? Sometimes you look at people's websites and you're like, wow, they have it all figured out. And then you go talk to them and you're like, oh no, they haven't figured it out either. They just have a really pretty website. And so it's really helpful. So on our end, as practices, like what do we capture? How do we capture what are we doing, right? So hats off and a shout out to all of our IT and data partners. We don't appreciate them enough. And so thank you to all of you that do that work in all of our practices. And so we are getting data from our EMRs and we're getting data from the payers, right? And thankfully, there are people who run data management platforms, and for our group here at the PHN, we use a vendor called Arcadia, but there's others, right? And thankfully, they make it a lot easier for us to be able to collect that data, integrate that data with information coming in from different sources, and then thankfully give us nice visuals so that we can interpret some of that data. It makes it sound really easy, but this, for example, is one data flow map for our network, and now we have a real appreciation for all of our IT and data colleagues. And the important part is not so much the specific details on this map, but rather sort of the complexity of it all, right? And at each step of this flow map, it's really important that we trust the data. So this whole validation process, And we are slowly, and most CINs across the nation that are doing this work are in different states of progress as far as how much data they're pulling into their data management platforms. The more data that's in there, the easier it is to actually get a true picture of what we're doing. And the really beautiful thing, getting back to those measures as defined by HEDIS or some other standard steward of standard measures, is that for the most part, if we stick to those standard measures, we can go to our data management platform folks and sort of say, hey, can we have this measure? And because it already exists, they're able to just put it in there. If we come up with our own measures, like, hey, we want to measure X, Y, or Z, but nobody else has really standardized that measure, then it's a nightmare, right? We go to them and they're like, oh, maybe, it's going to take 5 months. And so a lot of times the reason we are sticking to certain measures has to do with how easy it is going to be for us to track it. And the other really nice thing about standard measures is that it allows us to have the same conversation with different payers, right? So if we have we have a set of standard measures with one payer, as we approach another payer, can we say, hey, we want the same measures because we don't want our practices to have to, follow 50 measures at once at the beginning. Let's stick to some of the same ones. And if we can stick to standard ones, it's an easier conversation. Again, the specifics of the slide are not as important as the general spirit. And so what we're looking at here is that we can get reports out of our data management platform that give us specific, and this happens to be for combo too, so it's the adolescent vaccine measure. And we have started to build a framework for stratifying it by race. And this one is for race, but we're also doing some ethnicity work as well. So just for you to be able to sort of see, there's a practice report, there's a network report, and then gives us some progress to Chip's point about where were we last year, where are we this year, where are we going?
So we're going to get into the nuts and bolts after the break, but just in terms of setting the stage, we actually are going to spend some time with all of you sort of drilling down on social determinant screening and what do you do with the data and the results and connecting families to resources. That will be part of our June Future Pediatrics conference. It's just not ready for prime time now. The industry is still so immature. And while pediatricians in the AAP have been championing this forever, interestingly, this is entering the marketplace from CMS and Medicare around seniors, because they realize that, gee, if I'm homeless and I have all these other health issues, it's jacking up the costs for the country on the Medicare side. So it's sort of percolating up and percolating down, and we'll spend some time on that down the road. The other thing that helps is it's hard for each individual practice doing this as a one-off, and there are a number of reasons to sort of partner and collaborate and do these things together, because the payers are all using the same measures for all of us, but each practice is trying to solve for this individually. And I think part of what we are trying to do with our pediatric focused clinically integrated network is raise all boats and really help the practices that have figured out how to do this on their particular EHR, coach other like practices so that we can all improve. And I think one of the things that helps us is that, we're now over 50 practices and over 500 PCPs across the DMV. And that actually is beginning to give us enough critical mass to help us all learn, as well as begin to have some limited impact at the bargaining table. I'm not going to spend a lot of time about this. The pandemic sort of screwed this up a bit, but we have been moving over the last 4 or 5 years to developing the contracts and the quality metrics. And there are ongoing conversations still with other payers out there. I think, as Ed had mentioned, part of what's going to make this easier is beginning to sort of manage the data. These companies and vendors like Arcadia, there are others out there. When the day is done, it's figuring out how to get the data from our practices and EHRs and payer claims into a setting that provides us user-friendly information not just to understand the report, but actually to help figure out how to, one, improve our metrics and identify gaps in care for patients to actually not just improve quality metrics, but also you're improving visits and engagement and revenue at the practice level. These yours or mine? Okay. We're not going to detail the measures. You know the measures. You already get reports on them, and payers are already talking to you about those things. I think what we are trying to do is, pardon me, focus on a common core set so that we're not pinging all over the place with different measures for different people, but we can start to work on the same set of things and actually improve care across our practice. Because we all know when we see kids in our practices, we're not looking to see, I wonder who their payer is and what do I need to do for this child, around this metric. We're too busy seeing the kids and the families and moving for the day. So we need to have a common core set, and one serves all and raises all boats. And that's part of what we are also negotiating for when we sit down with the payers. And now we're supposed to wrap up. Claire, and pardon my editorial.
No. This is, I appreciate that far more than what I'm going to say. So really, we're going to end today, like, how can we improve? How can we add value? And all of you guys know it's quality improvement, right? So what is that? It's a structured approach to these small incremental changes that we make and measuring these benchmarks and outcomes to make sure the work that we're doing is actually benefiting our patients and improving those metrics. And for the doctors and pediatricians in the room, you can get MOC credit for it. This is one of my favorite slides. We show this at the value-based care cohort meetings for the network. And if you're a part of any of our MOC projects, you guys know this as providers and people that have tried to manage adult learners. But essentially, there are people-focused interventions we can do, like educating them, reminding them, changing a policy. But we all know those are less effective and less sustainable than making your EMR work for you, than finding the automated functions that can make this work. And so as a network, we're working really hard to find those functions, to push the payers and the EMRs to see those and clarify that for us so we can transparently give that information back to you guys around these metrics. And that's where we end. All right. I would say we have questions, but I think we're over time. Oh, okay. There is a break, but if anyone has questions, come join us.